Hi everyone, today we're going to be looking at an attachment-based perspective in working with and thinking about borderline personality disorder. And I'd like to start just thinking a little bit about my own interest in working with what I'm going to call BPD, just for convenience sake. Some years ago I spent a number of years working at Tara Psychiatric Hospital on the Ward 4 and 5, which works specifically with personality disorders. And in my time there, I came to understand borderline personality disorder from a much more multidimensional and in-depth perspective. And what I learned to recognize was that there are so many different manifestations of BPD, that every single person presents differently, often in ways that defy the basic symptomatic diagnosis that we are used to. And so I was drawn into a deeper interest and curiosity and also compassion when working with this particular patient population. And I do want to hold that word compassion in mind as I go through this lecture, because from my perspective and as far as I'm concerned, when I work with this particular population, the key factor in working successfully with them is working from a place of compassion in terms of really understanding the depth of the pain and the depth of the distress with which these people live every single day. Part of what has drawn me to working with BPD patients as well are those moments of breakthrough when suddenly the theory makes sense and suddenly all of the efforts that have gone into working with this particular individual come to fruition in moments of breakthrough. I have to say though that those moments of breakthrough are often very, very painful because they include insight, and they include insight into the impact of behavior and the impact of ways of being in the world, often on relationships and on people that are close to them. And so those moments of breakthrough come also with a cost, but they are certainly what makes the work worthwhile for me. I also really enjoy working with personality disorders because it is the one area in which theory and practice correspond. So all that we understand about the personality, about the self, about early attachment history, and about developmental theory suddenly comes to life in the practice room when we see it in working with these patients. That said, I have to emphasize though, as I'm sure many of you will know, that there are incredible challenges when working with BPD patients. Each session brings with it a potential challenge. It's sometimes very, very difficult to predict or to know what the individual is going to bring into the room. It is impossible as a clinician to remain separate from what is happening in the room, because so much of what makes up borderline personality disorder structure is relational. It's about what happens between two people, and most significantly, what happens between two minds. And so when you're sitting in the room, you are part of the drama, I'm going to say. You are part of the enactment of what this person lives with internally. It is taxing and demanding work because it calls on parts of ourselves as clinicians that we can quite often keep at bay. It involves very, very primitive feelings. It involves splitting and projection, and it involves the therapist in terms of what we bring in ourselves and some of the, some of the developmental challenges that we might have into the room as well. And so working with BPD is a significantly challenging area of work as well as a significantly rewarding one. One of the things that I find very interesting is the whole notion of diagnosis and formulation. And I think that with the atheoretical DSM classification system, we really are faced with a very, very static and quite inflexible listing of diagnostic categories and symptoms, which if you look at a list of symptoms, you can tick them off and you can say, yes, my patient falls into this particular classification. But we know, and I certainly know, that formulating a patient with borderline personality disorder is much more complex than that. The truth is, often what people manifest with when they are struggling with this level of personality disorder are areas of behavior which we all know. They're areas of behavior which we can all potentially regress to. And because BPD is a regressive disorder, in other words, it takes the person right back to early infantile and childhood behavior, it's certainly a place that we have all been to earlier in our lives. It's as equally an experience that we can all regress to in the face of significant stresses in life. And so diagnosing or making a diagnosis of borderline personality disorder based on a discrete frame in terms of what the person is presenting currently can often lead to inaccurate diagnosis. So a person, for example, comes into your room and they're completely decompensated, they're regressing in their relationship, they're showing volatile, impulsive behavior, perhaps there's even been some self-destructive or self-harming symptoms. I think it's very tempting to jump to a borderline diagnosis. But what we do know is that we have to establish a long-standing pattern and a long-standing history of behavior that is repetitive, that we see time and time again, the particular borderline dynamic coming up in relationships, coming up in work, coming up in the ways of dealing with the stresses in the world. And so I want to focus a little bit on diagnosis and formulation today. I also want to think about the important issue of managing our countertransference, managing how it is for us as individuals and as clinicians to be sitting with and working with somebody with BPD. Sitting in that space can be incredibly overwhelming, and sometimes holding on to what I'm going to call my clinical acumen or our thinking clinician's mind can be extremely difficult. And certainly there have been times when I've sat with patients where I've thought to myself, I simply can't continue, I can't do this with this person anymore. I want them to leave, I want to leave, I want to end this, because the influx of emotion, of intensity is just too much. And I think it's at those moments, in those moments where we really have to call on what we know, on the supervisory voice inside our head, on what we might call the third position, the capacity to observe what's happening in order to survive the moment sufficiently enough to get through it. Part of the countertransference experience, certainly at times, part of that experience can be being idealized, where we sit for brief moments where we feel we are the best therapists in the whole world and we can do no wrong, and we are the only person who understands this particular individual. And of course that can feel quite heady and very, very compelling, but equally we can be thrown into the pit of denigration and of absolute hatred, where we have to survive being the hated object, being the useless object, being the not needed object. And of course, as people, this can draw on our own self-doubts and our own limits in terms of capacity. And so again, surviving these moments is essential to this kind of work. What helps me to understand these moments, and often is post the fact, it might be at the end of the session or between sessions, if I can find a moment to think about it. The thing that helps me is to understand that when we have these moments of affect storms, of affect dysregulation, is to really understand that this is a crucial mode of communication in terms of what is happening for this person internally. Beyond helped us understand that it's at the breach of the boundary that we get the most information about our patients. In other words, when you're having an ordinary session and things are going along okay, well, that's good enough. But it's when there's the enactment, it's when there's the pushing of the boundary, it's when there's the projection into the therapist that the boundary is breached, and that's when we get the most information about what is happening. And that's also when there's the potential for some significant work.